when we are comforted with a patient that is having a high blood pressure, we must be careful in doing our investigations, and our investigations must be based on our clinical findings from history, physical examination. So, as we mentioned, I don't remember if I said this to you, but I will say it again. There's something called test threshold and treatment threshold. So, when I do my test when the symptoms give me likelihood that is close to the test threshold but did not surpass the test threshold, but did not surpass the treatment threshold. So if this is a diagram, here is 100%, here is 0%. At 30% of me being sure that this patient is having the disease, this is called the test threshold. At 90% of me sure that this patient is having this disease, this is called treatment threshold. And this 30% and this 90% is measured using likelihood ratios, which are obtained from observational studies and relative risk assessment in large studies and evidence-based clinical medicine. So, for example, if I have a patient with lower limb swelling and thrombosis, and she was postpartum lady that underwent Doppler ultrasound and thrombus were identified. I'm sure this patient is having hypercoagulability. Why would I do the dimer? I surpasses the treatment threshold, so I just give her the anticoagulant. I don't do the dimer because it will change nothing in the management of the patient. So I surpasses the treatment threshold. So as long as I am above the treatment threshold, I don't do the test. And once I am between the treatment threshold and the treatment threshold and the test threshold, I do the test. And if I am below the test threshold, I don't do the test unless I reach it, because I can't investigate malaria in a patient that does not have fever unless the patient is taking antibiotics. You see? So we have to be careful while choosing which investigations that we are going to do and which investigation we are not going to do. So routine tests for patients that presenting with high blood pressure are ECG, urine general, blood glucose and hematocrit, electrolytes, renal function, lipid profile, fasting lipid profile. These are the routine tests for these patients. Optional tests, you can measure urinary albumin creatinine ratio, and you can do more extensive testing to assist the patient if you think of a specific disease. So if you are considering renovascular diseases, their incidence varies according to the clinical situation, and it's properly very low, and it, it's it's always considered when the patient is having malignant hypertension. If the patient is having mild hypertension, the incidence is very low, 1%. And if the patient is having malignant hypertension, the incidence of renal vascular hypertension become very high, and up to 45%. So it's very variable according to the clinical presentation of the patient. If we have a patient with a mild hypertension, we don't think of renal vascular diseases. If there is a malignant hypertension and the patient is not responding to multiple medications, then we can consider this diagnosis. So how we test for it? We do radiological testing only if the patient have suggestive clinical clue. Only if you are going to do intervention. Okay? How we treat patients with hypertension and why we treat patients with hypertension. We do this because there is benefits from lowering the blood pressure and there is harms from high blood pressure. So the stroke incidence reduce. Is reduced by 35 to 40% when we are reducing the blood pressure, and the MI decreases by 20 to 25%, and the heart failure decreases by 50%. So I think this is enough. These are enough reasons for us to reduce the blood pressure and to maintain it low. It's not like diabetes. Diabetes, if you maintain the blood glucose very low in diabetics, you may increase the mortality because diabetic patients may suffer from hypoglycemia and may die from it. But in the setting of hypertension as a complication of medication and management is very rare unless the patient gets very old and have multiple medications. And so when the patient develop hypertension, multiple episodes of hypertension while he's on antihypertensive medication and treatment, you stop the antihypertensive. That's it. So for persons over age 50, systolic blood pressure is more important than the systolic blood pressure as a cardiovascular risk factor. So you start at 115. Cardiovascular risk factors double with each increment of 20 over 10 millimeter mercury throughout the blood pressure range. So from this range, any increase by this range, by this amount, double the risk of cardiovascular disease for the patient. Very sad.
Mhm.
Persons who are normotensive at age 55 have 90% lifetime risk for developing hypertension. Can you imagine that?
حاجة
If you are
حاجة
normotensive, if you are normotensive at 55 years, you still have a 90% lifetime risk for developing hypertension. Can you imagine? So these patients with blood pressure of 120 as a systolic and diastolic 80 to 89 should be considered pre-hypertensive, and they require health care modification, lifestyle modification. This is the new classification. The old normal become pre-hypertension. So the algorithm for the management. So lifestyle modifications, not at goal blood pressure. The blood pressure is less than 140 over 90 or less than 130 over 80 for those patients with diabetic and having chronic kidney diseases. You have two choices. So without compelling indication, you, if the patient is having a high blood pressure and is stage 1 hypertension or stage 2 hypertension, You can give medications, but there is no compelling indication, we say. And this stage 1 hypertension mean systolic blood pressure of 140 to 159, the systolic blood pressure of 90 to 99. There is no compelling indication. The patient have no diabetes, or the patient does not have prosthetic problem, the patient does not have heart failure. So there is no any compelling indication for a specific medication. We give the patient angiotensin converting enzyme, angiotensin receptor blockers, beta blockers, and calcium channels blockers. And thiazide is the most important. Thiazide is the first. Then all other classes can be considered. If the patient is having stage 2 hypertension, blood pressure is more than 160, more than 100 diastolic, and then we will add two drug combination, for most usually thiazide and AC inhibitors, or angiotensin receptor blockers, or beta blockers, or calcium channel blockers. So if there is a compelling indication, you give the drug for the compelling indication. Okay, this was the old treatment algorithm. There is a new treatment algorithm, which is the patient is having high blood pressure. So is this patient having stage 1 or stage 2? Pre-hypertension. Sorry, I will remove it and draw it again. If the patient is having hypertension, does this patient have pre, stage 1, stage 2, or complicated hypertension? So if the patient is having pre-hypertension, you just do lifestyle modification. If the patient is having stage 1 hypertension, then you do assess the patient for cardiovascular risk. If the patient is having cardiovascular risk factor, cardiovascular system risk is less than 25, then you do lifestyle modification. If the patient is having cardiovascular risk more than 25, then you give antihypertensive medication. If there is a compelling evidence or compelling indication, you give antihypertensive according to the compelling indication. If you don't have any compelling indication, then you give random antihypertensive medication. If there is cardiovascular risk more than 25, if there is stage 2 hypertension, instead of the cardiovascular risk, you give the patient antihypertensive medication along with lifestyle modifications. And if the patient is complicated, you stabilize the patient and you treat the complication, and then you give the patient antihypertensive medication accordingly, and you treat the patient according to the lifestyle modification. So lifestyle modification is fixed for all of them. For stage 1, you need cardiovascular risk more than 25 to start medications. Stage 2 and above, you always start medication. We are saying lifestyle modification. What are the lifestyle modifications? Before we go to the lifestyle modification, so if the patient is not at the normal blood pressure or the goal blood pressure, you have to optimize the dosage or add another antihypertensive or seek consultation. So what are the lifestyle modifications? Weight reduction, adopt dash plan, dietary, sodium restriction, physical activity, and moderation of alcohol consumption. course, we will talk about this analogy of moderation of alcohol consumption. So weight reduction, it's reducing the patient weight by 10 kilogram. The patient blood pressure drop 5 to 100 to 20 millimeter mercury. And as we said, why obesity increase the blood pressure and increase the heart rate and causes a steady state of sympathetic stimulation that mimic the heart failure. So obesity is a state of physiological tachycardia and it's a bad state. Another thing that we can do as a lifestyle modification is adopt dash eating plan, which is diet against systemic hypertension. This this affect the blood pressure by reducing it from 8 to 14 millimeter mercury. So the most thing that we can do to reduce the blood pressure is weight loss. After it, healthy eating. Dash con- contain the patient must eat fruit, avoid fat, eat vegetables, and avoid salt. If the patient have dietary sodium restriction, then the blood pressure may be reduced by 2 to 8 millimeter mercury. And if the patient have a moderate alcohol, if the patient have a increase his physical activity, the blood pressure may be reduced by 4 to 9 millimeter mercury. And finally, moderate alcohol consumption may reduce the blood pressure by 2 to 4 millimeter mercury. But you have to keep in mind that, as we said, medicine is about risk and benefits. Today, scientists say that any amount of alcohol consumption, even one glass, increase your risk of dementia from the general population. So you will have higher risks than the general population. Normal people working in this world, taking no alcohol, have a specific risk factor for developing dementia. There is a risk factor for total population. If you consume alcohol, your risk factor will increase as long as you are drinking. Your risk of developing dementia. I mean. So there is no other diseases that have their risk increase with weight reduction, with adopting DASH, with reducing dietary sodium, or with physical activity. Physical activity may increase risk of sudden death in patients with cardiac anomalies, with abnormal heart, with cardiomyopathy, and so. So continuing a lifestyle modification for prevention and management of the patient. What we're going to do, we're going to tell the patient to lose weight if overweight. We're going to limit alcohol intake. We're going to increase physical activity. This is to prevent the patient and to manage the patient. We're going to reduce sodium intake and we're going to maintain adequate potassium intake, because potassium intake affects the regulation of the blood pressure. And I can't actually tap this because it's going to take me into another places that I can go, and it's beyond the scope of this lecture. But you have to take potassium. You have to maintain adequate potassium intake. And if you want to talk about the overall cardiovascular health, you have to maintain adequate intake of calcium and magnesium. You have to stop smoking because smoking increases coronary artery disease risk. You have to reduce dietary fat and cholesterol. Okay,
Okay.
so what is dash? Dash, I said, fruits, vegetables, low fat, and it reduces blood pressure by 11 millimeter mercury and the diastolic by 5 millimeter mercury. So it's a sodium restricted diet and recommended 7 to 8 serving of grains products and 4 to 5 vegetables and 4 to 5 fruits and 2 to 3 low non-fatty dietary products and 2 or less meat products like poultry and fish. So we finished with the lifestyle modification. It's clear and sharp. So let's talk about medications. Classes of antihypertensive medication. They are diuretics, vasodilators, diuretics, vasodilators. Sometimes beta blockers may be considered as antihypertensive, sometimes not, and others are centrally active. So, ACE inhibitor is considered as vasodilator, angiotensin 2 receptor blockers considered as vasodilators, adrenergic inhibitors considered as vasodilators, alpha blockers are considered as vasodilators, beta blockers are considered as not vasodilators but reducing the cardiac output by so reducing centrally active maybe. They are not among the known classes like vasodilators and centrally acting and direct vasodilators like minoxidil and calcium channel blockers, potassium channel softener, nitric oxide medications. Some diuretics may cause vasodilation also. Others, diuretics like thiazide and loop. Okay, so indirect vasodilators were mentioned previously. These are indirect vasodilators. These are direct vasodilators, and diuretics are thiazide and loops. You all know calcium channel blockers. Potassium channel softeners are minoxidil, like minoxidil. It's a medication, and it's a potassium channel softener. And acting through nitrous oxide is a vasodilator like hydralazine, like nitrate. So our drug strategy for patients with hypertension. What we're gonna do? Decrease the total. We said that mean arterial pressure equal cardiac output times total peripheral resistance. So our strategy is to decrease the total peripheral resistance, decrease the cardiac output, and for us to decrease the cardiac output, we need to decrease the preload, and for us to decrease the preload, we need to decrease the body fluid volume, and decreasing the blood pressure may result in homeostatic regulation like reflexive tachycardia and edema. So we need to control tachycardia and we need to control edema, especially in patients with heart failure and in patients with ischemic heart disease. So decrease total peripheral resistance, decrease cardiac output, decrease body fluid volume, and when we decrease the blood pressure, we affect the heart rate and we affect edema. We affect the peripheral tissues and we cause edema. And you have to know that mainly, if this is the heart, I will draw it like a heart. This is the heart here. So, and we have here the nicotinic neuronal receptor in the center here, and we have a blood vessels here. So we gave the patient a medication that vasodilated this vessel, and the blood pressure dropped, and the baroreceptor activated the brain, activated the sympathetic autonomic nervous system because the pressure dropped, and the sympathetic autonomic nervous system sent fibers here, and these fibers sent fibers here in here. So heart rate will increases. Here it works via alpha 2 receptor. Here it works via beta 1 receptor. Here it works via alpha 1 receptor. So if I give the patient beta 1 blockers, and the beta blockers reduce the heart rate and reduce the cardiac output and reduce the blood pressure, can I induce reflexive tachycardia? I can't. So because beta blocker block the heart here, block beta 1 receptors, there is no reflex tachycardia that can occur with beta blockers if they used as antihypertensive medication. So if I use alpha blockers, I block the alpha receptors. I block the alpha receptors here, then vasodilation occurred, then the blood pressure dropped, then the signal will move from the baroreceptors to the brain, and the brain will send it back to the heart, and the heart will respond because the alpha receptor, the beta 1 receptors are free. I may give a medication that block alpha 1 receptor and beta 1 receptor, which is carvedilol. I may give a medications that block only alpha 1 receptors, and reflexive tachycardia will be a problem. So I will avoid alpha 1 blockers in ischemic heart disease. I may give a combination of alpha 1 blockers and calcium channel blockers because alpha 1 blockers causes vasodilation and calcium channel blocker causes vasodilation and bradycardia. But wait, what's going to happen to the patient is severe vasodilation and severe postural hypotension, and the patient may die without being able to compensate. So you do not combine vasodilators with each other. So alpha 2 agonists, centrally acting medications like before we go to this point, I will just go back and tell you why edema occur. Edema occur when we use medications like calcium channel blockers. When we use medications like direct vasodilators, when we use medications like alpha 1 blockers, but does not occur with beta blockers, does not occur with angiotensin converting enzymes inhibitors or angiotensin receptor blockers. So why do you think this is the
Sure.
it's okay it occurs in the setting of edema occurs in the setting of calcium channels blocker because calcium channels blocker increase the flow of the blood to the capillaries and increase the pressure and increase the filtration, and occurs in the setting of direct vasodilators because and alpha blockers because it causes sudden drop in the blood pressure and increase the angiotensin, which increase sodium and water retention and lead to volume overload. While in other medications, it does not happen because they block the salt and water retention, like beta blockers block the salt and water retention, and angiotensin converting enzyme blocks salt and water retention.
Okay.